Okay, so pneumonia, community acquired pneumonia, the patient is probably tachypneic and tachycardic because of the fever itself, or maybe because there's some element of hypovolemia going on over there with probably some shock setting in. Maybe there is some metabolic acidosis that's making him breathe in excess. And the SpO2 is low, obviously, because you have a dense consolidation over there. There is something sitting inside the alveolus and preventing gas exchange. Okay. The next thing is it can be heart failure, either a straightforward pre-existing cardiac disease which has been tipped off because of this infectious illness, or maybe it's an infectious myocarditis itself. In either ways, it's a cardiogenic pulmonary edema, wherein again you have fluid inside the alveoli that's going to prevent oxygenation from happening, and you have tachycardia, tachypnea for all those reasons. Okay, you have hypoxia as well. And I think somebody said nephrogenic also, which is very well possible. Okay, tropical fevers with let's say acute renal shutdown, and there is nephrogenic pulmonary edema, maybe metabolic acidosis. So it can be any one of this. Okay. Now, what do you think you need to know to be able to say if this is ARDS or not? That's another question. What additional? Okay, I think somebody has already asked me that. Somebody wants a PF ratio. Wonderful. Okay, so PF ratio is going to tell me the severity of the oxygenation deficit. With this history, if I tell you PF ratio is say 80, it can just be a pneumonia with a bad oxygenation. To be able to say this is ARDS, what else do you need to know? Okay, I got the responses out there. I think many people want to know the Berlin's criteria. Okay, so onset less than 1 week. Chest imaging, you need to have sort of the typical bilateral fluffy opacities in more than 2 zones on each side, all of those. And origin of edema, you should have some reasonable way of telling that this is not a cardiogenic edema. Okay, you need to show that this is non-cardiogenic edema. Okay, and yes, of course, PF along with CPAP or the level of PEEP. Okay, always when you ask for a PF, make sure you ask how much is the PEEP that's being applied as well, because sometimes minor corrections of PEEP can actually, minor PEEP can correct these settings. So you want to know the actual level of PEEP, because that also represents the severity. If you're having a PF ratio, let's say of 150 with a PEEP of 20, or even if you're having a PF ratio of 200 with a PEEP requirement of 20, okay, that's still terribly bad. Okay, so it goes hand in hand, right? So that is it. That's the Berlin definition, which tells you how to identify somebody with ARDS. That dates back to somewhere like 2012 or 13. Okay, so that's for your introduction. Okay, let's quickly come back to our patient. We have used volume control ventilation. All these lung protective goals are being used, and this is the ABG right now. FiO2 is at 0.7, ABG 7.28, PCO2 70, PO2 61, bicarb is 30, lactate 1.5. Girish, you don't have to run the poll. I'm sorry, because I've exceeded my time terribly. So I'm just going to give the answer. Okay, so here basically I'm trying to show a situation where the PCO2 has risen. PCO2 has gone to 70 millimeters mercury, and pH also has dropped to 7.28. I just want to stress upon, see all these maneuvers that I've given there: increased respiratory rate, decreasing inspiratory time, or increasing tidal volume. All these are going to basically be an attempt towards reducing your PCO2, which you do not have to rush to do right now. Okay, so the correct answer here is going to be watchful expectancy. As long as the pH is going to be above 7.28, don't worry about the absolute increase in your PCO2 value. In fact, this is what we call as permissive hypercapnia. It may actually be good for the patient. That doesn't mean you will induce a hypercapnia over there. If it happens because you are adhering to your goals of lung protective ventilation, accept it as long as the pH is well above 7.28. I'm sorry, above 7.20. You will not go ahead and induce one. Okay, Ecmo is when I've reached here. All of them have failed. I move on to Ecmo. We are not talking about that.